so therefore I've been paid pretty well almost by everybody on the market. And one of the more intriguing slides was how do I mitigate against potential bias. Basically, I'm not going to mention any brand names at all. The only brand I'm going to mention today is actually Victoria's Secret, so just want to keep your interest in mind. But I'm pretty sure it won't affect your professional judgment anyway, but other judgments, I'm not quite sure. Now, that was my original slide, so there you go, it's done. However, I have a disclaimer. I did a little bit of math, and I figured out each of you paid about $3 for my talk today. So if you don't like it, you get what you pay for. So basically, I'm just going to go over some common skin disorders in Asian patients, and it's my perspective as a GP. This is the city I came from. In fact, it looked like this today, but I assure you I didn't take this photo from an airplane myself. But it's a beautiful city, and it's sad to say Toronto is actually warmer than Vancouver today. But we do have a better hockey team. Where I live in Vancouver, essentially in BC or Lower Mainland, majority of the population is very similar to Toronto. We have a mixture of people. But in general, half is Caucasian, and we have a huge contingency of Far East Asians in Vancouver. In the city of Vancouver, I think the most recent numbers were that 1/3 of the population was Far East Asian or Chinese, Koreans. And then the other 20% or so is actually South Asians. So try not to be politically incorrect. Basically, you're either white, brown, or yellow in Vancouver. And that translates into Fitzpatrick's skin types 3, 4, and 5 in general. Basically, we need to go over is what I see as a general practitioner in my clinic and see what kind of disorders we see in general and what are the concerns. So I'm going to start with the cultural concerns first. Number one, cultural consideration. Especially in my practice, I have mostly Far Eastern Asian practice, obviously. Pigmentation. Nothing bugs an Asian woman more than pigmentation. It bugs the guys a little bit less, but typically I see mostly women presenting with problems. If you look at an egg, that's the kind of egg we don't want to be. We prefer to be leaves. Different variety of tones from 3, 4, 5, but nice and homogeneous, nice skin tone. And it doesn't help with the media in Asia photoshopping every single picture they have on the cover of magazines or in magazines showing that people have perfect skin. You won't believe how often I get asked this, how can I make my skin look like a model? And I tell them it's not that expensive, it's called Photoshop. In terms of what we're expecting to see, I think a lot of it culturally is that there's some socioeconomic assumptions. In Asian countries, in the olden days, if you had spots and you had lots of wrinkles, it means you worked in the fields. Whereas the rich Asians would probably be away from the sun, and you must have seen a lot of Asians with sun umbrellas as well. And typically, we're very lucky to be Asian in a sense that we look usually about 10 to 20 years younger. That's a genetic issue. And unfortunately, we do have a slightly earlier onset of pigmentation problems. So that's something that you should expect to see. I do also have to make another disclaimer here. I did quite a bit of putting a lot of personal sacrifice to make the next slide. You wouldn't believe how hard it is to look at pictures of Victoria's Secret models all day, trying to find the right one. But Erin Harriton is actually one of your famous ones. And believe me, I was looking at her face. She has quite a bit of pigmentation and freckles. And this is totally acceptable in the non-Asian culture. But I have yet to find a single Asian model on a magazine with pigmentation issues like that. So if I went and looked at the Miss India consultants and the contestants for Miss India in 2014 and Miss Korea for 2013, look at all your faces. It's all nice and clear, Photoshop, and no spots. And then I got to go beyond that and look at tan lines, which is quite tough as well. But I went from light skin tone, Fitzpatrick skin type 3 to 5, and absolutely no tan lines. So basically, in general, East Asians don't like tanning unless you're born in Canada, a term you may have heard, CBC, Canadian-born Chinese, or Canadian-born Asian, CBA for that matter. Let's get on to a little bit more common stuff we actually see. So in an Asian practice, we typically see almost pretty well everything you see in any practice. The typical stuff is still very common. I'm going to start with the disorders of hypopigmentation. First of all, PIH, post-inflammatory hyperpigmentation. It's very common, and it can be caused by any injuries or any inflammation of the skin. So cuts, surgery, burns, or any skin disorders that's inflammatory that disrupts the epidermis and dermis in general will give you PIH. And they typically last anywhere from 3 to 24 months. And it can be quite bothersome. And we get bombarded by patients, especially in an aesthetics practice, patients coming in post-acne, post-burns. They wanted to get that pigmentation off. However, time does heal everything. Typically, nobody would be left behind with a permanent scar unless the extent of the injury is more than second degree in a burn situation. Melasma, very common in an Asian woman. As we know, it can be classified as epidermal, dermal, or mixed. However, it's an easy diagnosis to distinguish between epidermal and dermis. For show of hand, I don't know how many people have Wood's lamp in the office. Anybody? Apparently, it's silly to buy a Wood's lamp these days. Apparently, they sell these little LED UV flashlights now. They're about $25 from Amazon.com. I can't believe I'm actually buying a lot of my medical equipment now from Amazon.com, and they're actually quite cheap to get one. So it's an easy way to diagnose or distinguish between epidermal and dermal melasma. And of course, the epidermal melasma is a little bit easier to treat than dermal melasma. However, with melasma, it's a genetic issue, as you know, a hormonal and UV. And what's interesting is what I found about some melasma cases is that it's actually affected by infrared. And how they justify that theory is that in Mexico, in the tortilla factories, where the workers are working with lots of oven all day, and obviously you're not in the sun, many of them do have melasma all over their body, their arms, and any exposed areas. So I think not just UV, you have to think about infrared. And talking about that along the same line, sun blocking is very important. If you look at the typical sunscreen we have on the market, if it's a chemical-based chemical sunblock, you tend not to block infrared. The only other one that literally blocks infrared to a certain extent are the physical blockers. So you will see them labeled as physical blockers, non-chemical sunblock, and probably the best ingredients you'll be asking your patients to look for is micronized zinc oxide. And of course, the higher the percentage is better. But I won't get into the sunblock issue too much, but the SPF number that typically see on the label only refers to UVB. And as you know, most of our sunlights out there is 95% UVA, so they do need a total full spectrum. It would be even better if they have some physical blockers in the ingredient. And other freckles, sunspots, and such, it's no different from Caucasian patients. And I believe there's another talk about lasers and issues earlier on today. Perhaps that's something that can be easily treated, so it's not a major problem for us Asians. The thing I want to bring up is that this is what we see quite often, often enough to sort of, you have to keep an eye out for it. It's Hori's macules. It's essentially named acquired bilateral nevus aorta-like lesions, macules. It's interesting how whenever I used to hear the terminology, a true dermal melasma, there's some thoughts that maybe it's actually a misdiagnosis. It's actually Hori's macules. It usually happens bilaterally on both sides of the face. It's never single-sided, and it's called acquired, so you can remember that usually onsets around age 20 and it gets worse in the 30s and 40s. But it does happen often enough. It's about 0.8% of the East Asian population. So for those of you who have a big Asian population in your practice, can you imagine 1 in 100 approximately women will be sometimes presenting this to you. Unfortunately, it's not that easily treated. So that's something that you can reassure them it's normal, but you have to tell them the bad news. It's very difficult to treat. And in my experience, sometimes lasers could help, sometimes it can backfire. Next one's a nevus of aorta. It's another not so common, but yet not so rare issue. They typically present when you're younger, puberty, or even younger than that. Now, the distribution is usually unilateral, it's usually one-sided, and it's along the trigeminal 1 and 2 distribution. And some people will have scleral involvement. So if you look for the purplish blue tinge in the whites of the eye, the interesting thing about this is that you have to keep an eye out for this. 4% of the people with nevus aorta will have choroidal melanoma. So they need an ophthalmology consult or at least a regular checkup. So given the fact that it happens in nevus aorta is about 0.6% of the population in the Far Eastern Asian population, and 4% of that, if you do your math quickly, I mean, it does add up. It's not common, but it's not something that you should miss. So next question I'll probably get asked is, how do you treat it? Bleaching, compounding, that's what we do. There are certain products available that's pre-counted. As you know, hydroquinone is very common out there. And I believe it's in the 70s, Dr. Kleeman came out with his Kleeman formulation for bleaching. I think most of you may have seen this before. So basically it involves 3 components. One is retin-A or vitamin A acid. Next one is hydroquinone. And there's betamethasone or any kind of steroid of some strength. You can vary it because, as you know, one size doesn't fit all in our population, so we need to vary the concentration, and you can play around with it. Start gently and then work your way up. The only thing you have to make sure you tell your patient is that don't go home and be sort of ambitious and put it all over the face, because if you start to bleach your normal skin and then bleaching your pigmented spots, it's still going to look the same. The contrast is still the same. So what I tell my patients is use a Q-tip, dab it on very lightly on the pigmented lesions, and don't rub it in. Now, we can vary that a little bit as well, and we stabilize it with a little bit of vitamin C. So it's always good to add a little bit of vitamin C. It seems that the compound does not oxidize as quickly as it would. Usually we find it probably lasts about 60 days before you have to get a fresh batch. And there are other components you can add in, kojic acid, azidic acid, and also arbutin. There's a whole bunch of other things that's sort of around, but there's really no heavy-duty clinical trials on all these. Now, some patients may ask you, well, if I'm using steroids all the time, every day or every other day or long-term, would I see the atrophy or the other skin changes that you will see, you imagine you would see? Interestingly, is a product that was available in the States many years ago, and it's called Triluma. Oops, I must have was mentioning brand names. But basically, it's a combination of the first 3. And they've done 12-month studies out, and they have not picked up a single case of sort of major skin changes to make you worry. So why is that? We're telling patients not to use steroid creams on their skin for more than 1 or 2 weeks at a time, And here we are telling them to put this stuff on for a year and not worry about it. Obviously, I think my theory is on that is that I think retinoic acid actually vasodilates, whereas the steroids vasoconstricts. So there's a little bit of a balance to that, but who knows? And going back, I forgot to mention something. If you're sending your prescriptions to a pharmacy, make sure it's a compounding pharmacy. It's not a typical mixing stick and then mix and then put it in a jar. Usually when I see the prescription done in a jar, I know, chances are it's not a compounding pharmacy. Would be best if you ask them to put it in a soft tube like that, and there's actually newer types of dispensing pen, they click. So one click gives you a tiny pea amount, and you can actually have it a pea-size amount sort of determined by the pharmacist. That kind of device would actually reduce the amount of oxidation, so the medication will last longer for the patient. And plus, you be rest assured that the patient's probably not using it too much. So make sure you send it to a good compounding pharmacy, because all those materials have to be mixed in an ointment mill. It always works best if the pharmacists have a machine that actually mixes it rather than hand mixing. And I'll tell you a funny story. A patient actually went to a regular pharmacy, had a mix, and been using the same stuff. And just like anybody else, I give a prescription. I never never check on your prescription. So one time she actually got sent to a compounding pharmacy, and she said, "Oh, I don't like it. They cheated me out of stuff. I can't feel any of the grittiness from the cream." So she thought, a gritty compound is actually the correct one. No, it's actually, if it's mixed properly, you should have a nice, smooth cream texture. So just to be fair, we can't talk about hyperpigmentation without talking about hypopigmentation. I'll go over it quickly with you. It's not that common. You see these in Asian, more common than any other races. So vitiligo, obviously, if you're darker skin, it's going to be more apparent, and it does bother them a lot. Now, Tinea Versicolor is very common as well. Basically, it can be diagnosed with a skin scrape and a KOH for those of you who still have a microscope in the office. And of course, the good old Woods lamp, or now the UV flashlights that you can get. Now, pityriasis alba, it's very common in Asian children, especially teenagers. I see a lot of kids with this, and the parents bring them in and say, "Well, you got to fix that. They have some kind of disease." Well, it is a skin disorder, but it's thought to be a form of eczema. And they're a little bit scaly, and the easiest treatment is basically either good moisturization, just like any eczema, and probably a bit of steroids if they really get really desperate. However, you have to let them know that the skin would not be pigment until the next time they get more sun exposure. So it may look like you have done nothing for them, but in reality, they're better already. And then, of course, there's always the idiopathic gouty hypomelanosis. It's actually quite common. The easiest thing to remember, I'll just basically reverse freckles. Eczema, very common in Asian babies. It has been shown on 2 separate studies, one in San Francisco and one out of Australia, that Chinese babies tend to have more eczema. There was a UK study that theorized that that's not true, but they're basing on the sort of the cultural issues. But I believe the American study and the Australian study precluded that. So I think I do see more eczema in Chinese babies or infants than any other race that I've seen. And there's also increased concern culturally, as you know. If you speak to family is a big thing, but Chinese babies, they have to be born perfect. They can't have any skin problems. It's shameful for the parents to bring their kids out if they have eczema, just because it looks like they're not looking after the baby. Typically, what's interesting is that if any sort of child or even adults with eczema, when they return to their home country, many of them in the more warmer and more humid places, the eczema actually gets better, and I think it's probably because of humidity. pretty well the same treatment modality. There's no, moisturization is key. And occasionally, for severe cases, you might want to consider steroids. And there's always interesting talks about severe eczema, long-standing chronic, that it might be more of a bacterial infection involved, but that's debatable. Acne vulgaris, that's something I see quite a bit. And interestingly, that if you look at the incidence rate in Hong Kong, it's 91%. Now, I'm not quite sure if that's because of the genetic nature or the environment, but I believe it's probably stress-related as well. In Asia countries, these kids actually have to compete to get into university, and one exam does it all. And I was talking to somebody from Asia, and they were telling me that around grade 11, grade 12, the 17, 18-year-olds have very severe acne. And I wonder why. You know, one test one day determines the rest of your life. There's a major concern that's different from a typical Caucasian patient would be the PIH we talked about. They tend to leave marks a lot longer, but we reassure them that they will go away eventually. There's a specific area that I want to bring up is because I'm going to be talking about the keloids and hypertrophic scars later. But if you see sort of severe acne or cystic acne in the jawline, treat it aggressively. Many of them will end up with keloids, which is a bigger pain in the ass to treat later on. And treatment modalities are the same. I do put patients on isotretinoin orally. Now, it's common to see, I know many of you, it's common to see a high bilirubin, it's like a high normal pre-treatment anyway. So I have seen many patients actually, you know, with a bilirubin of 18 go up to 22, 23. I haven't had any issues with patients like that. We kept them like that. And about 20 years ago, when I was seeing patients, I would be a little bit more concerned with hepatitis B carrier states back then. But I think since then, all the even the new immigrants, children from Asia, they're being vaccinated at birth since the early 90s. So we tend to see a lot less hepatitis B carrier states. So that's something that you might want to watch out for. You know, check, make sure their liver enzymes are okay. I'm very sort of keen on doing a pre-treatment blood test, and then definitely follow up by monthly or bi-monthly blood tests to follow them if they're on oral isotretinoin. Hypertrophic scars and keloids. Basically, much higher incidence in Fitzpatrick skin types 4, 5, and 6. Basically, it's over the skin areas with high stress level, extension surfaces, midline areas, and ears. We actually, you may see a lot of your Asian patients, if they tend to be in your 30s or 40s or 50-year-old range, you might see some of them coming with big keloids on the deltoid area. And that's because in Asian countries, they back 40 years ago, 50 years ago, they vaccinated every baby with BCG. And they've done your smallpox there as well. So typically they would do quite a bit of skin damage there. And being an area that's prone to keloid, you tend to see keloids and large keloids in that area. Basically, there are hypertrophic scars and there are keloids. I just made it very simple. You know, depending on how far it spreads. Keloids tend to spread beyond the original wound, and they tend to last more than 2 years. Treatment's the same, intralesional injections, and silicone gel and sheeting does work. Don't ask me why, because I don't think anybody really know how it works, but it does work. Problem with the silicone sheets is that it's very difficult to use, and very, you know, patient compliance is very low, but it does work. I won't get into the treatment modalities too much at this talk. I think most of you are experts already in your own practice. So I want to show you some pictures of keloids. The first picture actually demonstrates different sizes. They tend to look like that, and this picture is most likely taken from either from our chest or the back, most likely in an acne case. And then again, surgical scars. Now, what happens when that those little tiny keloids, if you let them go and become stay active for a longest time, especially in a younger patient, they tend to grow into a sort of a bow tie distribution. Now, the key thing is to inject the leading edge of the keloid. It's interesting how it spreads out beyond its border like that on a 2N. What I see quite commonly is that a lot of Asian women pierce their ears and they end up getting a small keloid there, and if you leave it long enough, it does grow, which requires first surgically removing it and then injecting it after the treatment. But that's something that I always warn my patients about when I see a young Asian woman walk in with 5 different earrings on their head, just going, oh. I show them a picture of this to make sure they don't get number 6 done. Psoriasis is pretty well the same in Asian patients, but a little bit lower, not by much. A Chinese layperson's terminology, many of you probably heard this terminology if you speak any form of Chinese. It's called Kels skin fungus. They named it fungus, I guess in a traditional medicine way. They thought it looked like a fungal infection, but obviously you do have to educate your patient that it's not an infection. Similar treatment modalities, and if it's severe enough, if we're treating them with UV, there's actually a lower incidence of melanoma, so that's a little bit, I guess that's a plus for Asians. And that's pretty well my talk, 27 minutes. And don't forget, we have better Chinese food out there. Okay. Is there any questions for me? Should I hop into the next one? Go for it? Okay. Well, the next one's a little bit more, just put all your pens down and stuff like that. It's more entertaining than anything else. Basically, my practice, I do a lot of aesthetics work, so I end up doing a lot of sort of fancy off-label stuff, so I have to throw probably a lot more disclaimers on this talk than any other talk. Same thing, I've been paid by U of T, CPD for this. No company has helped me to come here today to speak, so I will not discuss any brand names or any company's products in general. The same disclosure slides. Mitigating potential bias. Basically, I'm not going to mention any brand names, so nobody's going to go home and start buying any more of somebody else's product today. I do have to give you warning. I'm a little bit of a sort of left field guy. I have to use the word emerging use. I can't just use the terminology off indication anymore. I've been told that my stuff is actually way beyond off indication. So you have to forget what you saw today. Okay, what happens at Liberty Grand today stays at Liberty Grand. Now, all stuff I talk about eventually will get HPV or FDA approval. My guess is about 2025 and 2030. And don't laugh, there's another slide I'm going to show you later that you realize why. So basically what I do is non-surgical aesthetics, botulinum toxin, and you know which brand that is. And there are actually 3 major brands approved in Canada right now, and I won't get into it. But as you know, it's been around, believe it or not, 20 years plus now. The other material I use quite often is a filler. Basically, that's exactly what it sounds like. It's something to fill. But there are a variety of products out there, and the most common ingredient nowadays is hyaluronic acid. And then there are technologies such as lasers, radio frequency, ultrasound, all sorts of LED lights. I'm going to focus my talk today on the injectables today, because the technology side will probably take me another 5 hours, and I'm only given 20 minutes, so I'm going to flip through the slides very quickly. First of all, gabapentin. Everybody knows how Botox works, I hope. If not, look it up. It's pretty easy. How toxins work in general is relaxing the muscle of expression. There's no such thing as an innocent wrinkle. Every wrinkle you see on your face is caused by an expression or some kind of gravity or fat. There's no such thing as an innocent wrinkle. So we have gone now from 20 years ago, try to reduce the entire wrinkle. We want to have people have absolutely no wrinkle, which also means no expression. We have gone away from doing that. Now we're trying to leave them a little bit. So as you can see in this photograph, that we reduced most of the wrinkle, but we want to leave a little bit behind. Crow's feet. I truly believe in what I do, and I truly believe in the safety of the products I provide to my patients in service. If you look at this beautiful, good-looking gentleman, that's actually me. That's my photo. But those pictures were taken probably about 12, 14 years ago. I don't know. It's been a long time. Now, believe it or not, everybody knows about the botulinum toxin being used to reduce wrinkles for crow's feet. It was FDA approved 2 years ago, even though we've been doing it for about 20 years. Foreheads, same thing. We are trying to reduce the foreheads nowadays rather than give them absolutely no wrinkles. Like this gentleman we've done many, many years ago. Fantastic job. We used to use this as a promotional slide in my clinic to see how good we are, how amazing it looks. Unfortunately, the gentleman couldn't even raise his eyebrow, and he looks like he's sleeping all day for about approximately 3 or 4 months. He was happy about his forehead wrinkle, but I don't think he looked that great. In Asians, Far Eastern Asians, we don't have any we have very short lashes, thinner, and of course I purposely took out the name of the product, and I think most of you would know which one it is. There's only one product that's a prescription product that's approved in Canada. It's something that can grow your lashes. It's basically a prostaglandin F2 receptor modulator, and given daily application in about 3 to 4 months, you will see a decent amount of eyelash growth. And this is actually my staff, and I did not know until I asked her later, did she put anything on her eyebrows? And she did. The stuff actually works on eyebrows, and it's under development for scalp hair as well. But it would be very expensive to use it in its current form for a scalp, because I think it's $200 a bottle for a 5 ml bottle. So it's a little bit more expensive than the toe fungus product, but I'm sure a lot more women would pay that kind of money for that. Now, my next talk is actually about facial shape and contouring. I went out and looked at some of my favorite movie stars. And it's interesting, I sort of picked a few from each Fitzpatrick skin types out there, except Halle Berry. I think she's a little bit light for a 6, but my wife was looking at me, putting all these women's slides on faces on there, and she said, well, what happened to guys? So I put George Clooney on there. And then my daughter walks by and said, well, he's too old. Let's get something younger on here, so that's better, all right. But what we're looking for is a sort of shape. Female and males are very different. In females, if you look at them, they tend to have a more youthful look by having a shape more like an egg, or some people refer to it as a V shape. And you will see some Asians taking photos, and they're going like that. When you're taking photos like that, supposedly enhances that look. Now, talking about facial shapes, the ideal shape is more of an oval or heart shape. Very often you will see patients come in, or Asian patients come in with a square jaw, and they tend not, we want to reduce that squareness or the bottom heaviness by reducing the sides. And how we do that is basically we would inject botulinum toxin. Now, this is a promo website from United States, and now she looks better with her crow's feet, obviously her eyes, but you could notice that her jawline is still very square. So that's a patient that came and saw me, and she was complaining about her masseter muscles being sort of hypertrophied, and she would like to have that reduced. So if I inject the botulinum toxin, and if you wait 4 months, that's the kind of result you get without surgery. So a lot of your Asian patients, for those of you who do aesthetics, they'll be coming in asking for this. It's one of the most common botulinum toxin procedures now for younger population. I would say age 35 and under. And that's another example of what you can achieve with just by injecting a medication and 4 months later. It's actually one of the safest injection procedure that we can do nowadays. And basically how it works is by weakening the muscle, you actually atrophy it with time, but it's very safe. Given about 4 months to 8 months, they'll recover to original size if they choose to. And you can actually, once you examine the size of the muscle, you can determine that a patient's suitable or not. I used to think, patients such as this could not achieve a better result, so simply there's so much facial fat on her. But her musculature was so big that it did make a significant difference. Another thing that we, us Asians, like to have is sort of a higher nasal bridge. We're not born with one, but all the photos and magazines, and in fact, a lot of the movie stars and models have surgical alterations to their nose. And this is what you can do. They can literally walk into your office and walk out with a difference like that without undergoing surgery. That's another example. And then sometimes it's not just about nasal bridge, it's about the actual shape. So we can correct a few things to a certain level, obviously, but they do appreciate this kind of procedure. And something that they can do a touch-up very quickly